Good afternoon. Welcome to this webinar to explain the Massachusetts Community Tracing Collaborative, or CTC. My name's Stephen Kadish. I'm Governor Baker's former Chief of Staff and have now been helping with the Massachusetts COVID-19 response, including standing up the CTC. Before we begin, please note all lines are muted and will remain so for the duration of the webinar. If you have questions, please use the QA box on the right-hand side of your screen, and would also appreciate if you indicate the state or other jurisdiction that you're viewing from. We'll answer as many questions as we can at the end of the presentation. And then finally, just a reminder, this meeting is being recorded. We put this presentation together specifically as a way to help other states, cities, and counties to understand why, what, and how we are approaching contact tracing in Massachusetts. Governor Baker announced this effort on April 3rd. We made our first outreach calls from our new call center on April 12th, Easter. Less than 1 month old, we've done a lot and learned a lot and look forward to learning from you. We have a long history in public health, doing and learning. The first public health agency in the United States was created in Boston in 1799, and the Massachusetts Department of Public Health just celebrated its 150th anniversary in 2019. Let's begin. Next slide, please. Our speakers represent some, but not all, of the key members of the Mass CTC team. They're listed here in the order of presentation. On this page, please note the website for more information and Kelly Driscoll's email, which is very small at the bottom, as your main contact. Next slide, please. In the next 30 to 35 minutes, we'll discuss our approach to contact tracing, the fundamentals of any similar effort, and the specifics of how we stood up this new entity, including organizational structure, roles of key partners, the technology selection, and messaging. We'll close with a review of key budget considerations and the risks we have resolved and those that we continue to face. Next slide, please.
Thanks, everybody. This is Jim Yong Kim. I'm one of the founders of Partners in Health, one of the partners on in this project, but also a physician trained in infectious disease. And up until about a year ago, I was president of the World Bank Group. At the World Bank Group, I spent a lot of time thinking about fiscal policy and monetary policy, money that governments use to carry out their goals and to try to achieve outcomes in the economy. And monetary policy, the way that central banks adjust the money supply, adjust interest rates to get the best possible outcomes. And one of the things that has struck me from the beginning is that we are using such huge weapons, bazookas, the nuclear option in fiscal and monetary policy, but we have not been investing in the kind of public health response that we need to tackle this virus. That's why I'm especially grateful to Governor Baker and Secretary Sudders for hearing me out and our team at Partners in Health out about a little more than a month ago when we said that it's not too late. The people who've been saying it's too late have partly been using their own judgment as to what's possible. And the public health community in the world has had a long history of underestimating what it is that we could do. At Partners in Health, we started projects on treating drug-resistant tuberculosis in slums in Lima, Peru. We treated HIV in Haiti. We tackled cholera in Haiti. We used community health workers to do contact tracing for Ebola in West Africa during the Ebola outbreak of 2014. So we've had this experience of going up against a public health community that has said things are not possible. In the case of the United States in particular, it shouldn't be surprising to us that we had to retreat so early. In 2018, there were $11,000 per person spent on medical care and only $286 per person spent on public health. But the point that I made to Governor Baker was that it is not too late and we've got to get started. These are the 5 elements, part of any public health response: social distancing, contact tracing and testing, quarantine and isolation, and treatment. Next slide, please. One of the things that we learned early on, and this data keeps getting confirmed again and again throughout the world, that social isolation does something very powerful. It stops the transmission of the virus between households. But then what we're seeing in country after country, and you saw some stories of it recently in Spain and Italy, is that what then happens is that transmission shifts to within households. And so social distancing is extremely important, but it won't get you with that radically downward curve that you saw here in Wuhan. If you look at Australia and New Zealand as well, because they implemented all 5 elements from the very beginning of the public health response, they're also seeing their curves go down dramatically. So on the one hand, we think contact tracing is extremely important, because if you can test enough people, if you can identify their contacts, and if you can isolate and quarantine to stop not only transmission between households, but transmission within households, that's when you're going to see the curve of new infections go down dramatically. Next slide. What I want to stress is this is not something new. This is not something that we invented. This is simply part of the best public health practice systems that we've used to tackle every epidemic so far. The problem has been that we've given up on the public health practice too early. Again, I think a big part of it is the fact that we haven't invested enough, and also the fact that we haven't had the kind of testing we need to do it. But this is a very time-tested strategy that we know works. In the simplest form, it's just reaching out to the people who are infected and reaching out to their contacts to stop the disease. We've had this experience in many, many different places. And one of the things that we've been finding from the program is that the human touch is extremely important. There are people who've said, why can't you just do all of this electronically? Well, there's no country in the world who've done it purely electronically. The countries that have done it well have often used the technology to enhance the person-to-person response. But what we found is that people are craving the ability to talk to another human being. We have to build the analog system and then later, as the programs get better and become more relevant, we add the digital piece to it. In Massachusetts, as Steve mentioned, we're very lucky to build on the deep experience of the oldest Department of Public Health and some of the most well-established, highly functioning local boards of health. And everything we do in the Partners in Health piece of it is to build on things that are already happening. In normal circumstances, they could handle this, but the number of patients, the number of cases and the number of contacts are so large that we needed to add to the system that was already in place. And so this is how we built the Massachusetts Community Tracing Collaborative. This is a scalable workforce, and it's a call center that has the ability to support the local boards of health and the Department of Public Health. Now, let me just end by saying this. 4.5 weeks ago, when I first had the conversation with Governor Baker about a contact tracing program, there was not a single state that was talking about doing this on a large scale. Contact tracing was dismissed by most public health experts as too late, too difficult, too big. Now we see that contact tracing is even part of the White House's plan to get us out of the lockdown situation. You cannot loosen social distancing measures without knowing that you have the testing, you have the contact tracing team, and you have the ability to isolate and quarantine so that once you loosen the restrictions, every time there's a new case, you can immediately jump on it and then squash the outbreaks as they happen. So this is the tried and true public health. This will help us, we think and we hope, drop the curve downward much more quickly. And we need to put this in place anyway if we're to have any hope of loosening social distancing. Thanks very much.
Next slide, please. Thanks. Thanks, Dr. Kim. So as Dr. Kim mentioned, not only is contact tracing not too big, too complicated to take on, it's actually an essential kind of leg of a three-leg stool. And in Massachusetts, we are approaching kind of any decisions we make about policies, loosening social distancing, and approaching good sense measures to reopen the economy by looking at testing. Do we have sufficient large-scale decentralized testing? Like many states out there, Massachusetts is limited right now by supply chain issues to be able to stand this up. And so it's a work in progress. Do we have supports for quarantine and isolation, not only for folks that can safely quarantine and or isolate in their home, but those that are homeless or housing insecure, and those that live in crowded environments that with maybe one bathroom for a number of people? How do we set up those? We're also working on strengthening that leg of the stool. So, you know, I often say we're building this plane as we're flying it, and we're strengthening each of these legs as the days and weeks progress. But contact tracing is a critical pillar to be able to make informed, scientific, humane decisions. So some grounding principles we had as we approached standing this system up. We wanted to reach everyone that had been exposed to COVID. That meant we need to come up with a model that could support a workforce to call up to 10,000 people a day as we hit surge in our hospitals, and then social distancing gets loosened, contacts go up. We wanted to build on the foundation of local public health. Massachusetts has a lot of built-in strengths. We are lucky to have such a long history with public health. We are lucky to have partners in health in our city. And we also have 351 towns and 351 boards of health. So that created a unique challenge to Massachusetts to kind of regionalize really quickly and best utilize the strengths of local public health in a rational manner for a statewide initiative. One thing the local boards of health definitely bring to the table is the cultural competencies of their neighborhoods, of their citizenry, the language needs, the various social dynamics that we need to be aware of as we are reaching out to people through their phone and asking them to be vulnerable with us. One thing that was really important was having a single system of record in Massachusetts. You'll hear more about this. The record is MAVEN, the Massachusetts Virtual Epidemiological Network. This network holds a ton of data and has since the early aughts. We needed to make sure that the integrity was not compromised, and so we built a Salesforce system next to mirror MAVEN so that the single source of records for all epidemiology would remain pure. And we needed to make sure that whatever system we stood up as a sister system could integrate with MAVEN. I work right now in the COVID-19 Command Center, which was stood up by Governor Baker mid-March, and we all have kind of our own work streams. The contact tracing work stream is associated with the local boards of health, but there's also medical surge, there is testing, there are nursing home testing, shelters and quarantine, as well as staffing, getting volunteer or other medical staffing to facilities that might be short. It was critical to have a direct connection into the command center so that all of the linkages and to those work streams were incorporated and thought about as we are thinking about contact tracing. This is a voluntary program. We can't make people talk to us, but we can make it as safe and confidential as possible so that they can feel comfortable. And then also, insofar as connecting to local boards of health and understanding the social resources that are there to connect people to for food insecurity, or violent situations, or a whole lot of other things that can pop up in people's lives, especially if they're sick. We wanted to make sure that we had a good grasp of all the other resources that were available in each community. Next. So when Governor Baker started the COVID-19 Command Center, one of the immediate needs that was brought to our attention from the local boards of health was the need to support contact tracing. Many of the boards are in very small towns and maybe had one part-time person that usually runs health department functionality, and now we're overwhelmed with all the needs. And so we built on kind of the local board of health contact tracing work, who are typically the people that do this epidemiologic outreach for folks with TB, other types of disease. They are really good at the complex cases. They really know their congregate care settings. And so wanting to maintain their ability to really reach out and touch the people that they've already worked with because of their complexity or because of where they live, we wanted to be additive and support them however we could. The first wave of our effort was we engaged, the second day of the command center being open, we engaged the academic health departments for the schools of public health in Massachusetts. We currently have 12 and a cohort of about 1,900 volunteers. One of their first tasks was to really integrate themselves into the local board of health and support with contact tracing. As we are moving towards the community tracing collaborative, these volunteers remain in local boards of health and are doing translation services, policy analysis, social media help, and outreach to seniors and other core functions that the local board of health still needs support on, while all of the contact tracing is now being integrated into this larger Community Tracing Collaborative, or the CTC, which is our large-scale, centralized, virtual contact tracing. It is, as Dr. Kim mentioned, a human-to-human endeavor, ultimately, but enabled by good technology and focused on integrating into the community and supporting people not only with their COVID-19 experience, but with the other supports that they might need right now throughout this pandemic. Next slide, please.
While contact tracing was clearly not new in Massachusetts, standing up this massive force to address the scale of the pandemic would be. Time was the enemy. We wanted to be able to reach every COVID positive person in their contacts as quickly as possible. So to do so, we focused on the establishment of a robust call center to be the engine of the contact tracing effort. It was a priority of Governor Baker. It represented a way to begin to attack the disease. To operationalize, we needed an experienced workforce partner, an experienced CRM, customer relations management, call center operator, a very effective systems data integration plan, and a significant media messaging plan to explain why and what we were doing. We also needed a strong, quote unquote, general contractor to put it all together. Next slide, please. Fortunately, we had experienced leadership in the Commonwealth's Health Connector. This is our state exchange operator of the Affordable Care Act. Under the leadership of the Connector's executive director, Luis Gutierrez, we began to move from concepts into contracts, idea into organization structure. And now, next slide, please, let me introduce Luis.
Thank you, Steve. On slide 11, we show key components of the contact tracing organization. The unboxed elements towards the center right, we've already been discussing: the state and local public health authorities and the centralized state epidemiological database known as MAVEN. And they're the vehicles through which contact tracing is undertaken for infectious diseases in normal times. What's been added at the start of this pandemic, starting with the blue bar at the top, is a COVID-19 command center reporting to the governor, which in turn on March 29th authorized the assemblage of the boxed elements on the left. The Massachusetts Health Connector Authority, which I direct, contracts for the efforts of 3 essential expanded tracing pillars: workforce partners, a technology call center partner, and digital automation partners. Partners in Health, a global not-for-profit with deep experience in infectious disease containment, is our principal workforce partner. We've received further in-kind offers of staff support from the local Blue Cross Blue Shield of Massachusetts, and also offers of staff support from community health centers in Massachusetts. Accenture, using Salesforce, is standing up our call center. And we have a company called Buoy. You'll see them at buoy.com, where you can see Massachusetts's specific application at buoy.com/mass, M-A-S-S, is the first addition to our consumer automation supports. This effort went from authorization to initial pilot outbound calling in the space of 2 weeks, and is now staffed by over 800 staff and on the way to 1,000 by the beginning of next week. Next slide. On a daily basis, the command center manages a twice daily stand-up call among the contact tracing collaborative partners. In the morning, with senior principals to highlight so-called Mayday topics and urgent next steps, and at the end of the day to discuss metrics, progress across all swim lanes of effort, and dive into special topics. For most people on the project, the days are very long, 7 days a week, and the swim lanes in the upper left graphic are how the major efforts within the project are grouped. Staffing and call center performance, the call center CRM and other applications, policy, protocols, scripts, and clinical interface, communications and marketing, and monitoring, evaluation, and reporting. With that, I'll hand over to Emily Rowe of Partners in Health to discuss the contact tracing roles.
Thanks, Louis. Welcome, everyone. I get to tell you about the workforce that we've put together. And we've really built a program based on teams and based on people who are in combination with and supported by the technology you'll get to hear more about. And I get to talk to you about this amazing workforce of people that raise their hands to help out Massachusetts. It's very big. We've had over 32,000 applicants so far. There's 850 at work and another 200 we were just teaching online this morning, and we'll grow to be 1,200 strong for the core roles that you see on the screen there. These people are paid commensurate with the market at rates approved by the Commonwealth and are around or a little bit above census workers, and they're on contracts and provided with health insurance. They speak more than 20 languages and are well representative of our local diversity in Massachusetts. And they're really helping us build the program as we go. And their frontline experience has been one of the greatest resources that we've had so far as we learn and build this together. So I'll talk to you about those 3 core roles if you move to the next slide. So case investigators, and the next one's going to be contact tracers. There's really a lot of movement between these 2 functionalities, which is one of our lessons learned. The case investigators are team leads supervising several contact tracers, recruited and hired by Partners in Health, working in partnership with a recruitment firm, focusing on diversity in hires and language skills and people who know the context in Massachusetts. Many of these people are clinical, but not necessarily. We have retired nurses, we have retired lawyers, we have graduate students, accountants, activists, social workers. They are reaching out to the cases. So they are calling people diagnosed with COVID-19 and they're armed with scripts, they're armed with training on the software and a team behind them to answer questions. And they gather epidemiologic data. They aren't doing clinical assessments. And then they walk through those people's lives in the last time period to gather their close contacts, to get a contact listing of contacts we need to inform. And then they're also doing a home assessment to identify any vulnerability that needs to be addressed during the period of home isolation, to refer them to another cadre I'll tell you about. On the next slide is the contact tracers. So again, there's cross-pollination of roles. So many of the people hired into this role are also doing case investigation. Their primary role is to call exposed contacts of COVID-19 patients, letting them know about the exposure that they've had, checking on their symptoms. If they're symptomatic, referring them to a provider to get a test. These folks also come from all walks of life and are hired and trained and supported around communication skills, empathy, and also need to be able to use their computer and smartphone technology. It has not been a problem to find highly motivated people. I mentioned before how much we're learning from the team, and we've been impressed at their ability to create community with each other, even though we're living in a virtual world right now. They also are conducting home assessments to see if people are safe at home during the quarantine period, and then they can bump things to their supervisors in order to communicate directly with the local Board of Health on high-risk cases and contacts, and then they can also refer to the resource coordinators who are on the next slide. So resource coordinators often are social workers, nurses, and others that have deeply rooted community experience. This is a critical cadre for our contact tracing program to work because we know we need to address social vulnerability and really support people throughout home isolation and quarantine. They are charged with this very tough task in connecting cases and contacts with resources during this time. In the past few days, we've seen them sort out nebulizers for people in home quarantine, confronting food insecurity, confronting overcrowded housing, a need for masks at home to care for family members to care for a case. And Kelly Driscoll in her part mentioned the three-legged stool. So the resource coordinators are really interfacing with all the actors, including the state and the command center, local boards of health, mayor's offices, community groups, and other resources to facilitate those connections as we uncover social vulnerability for cases and contacts during this time of great uncertainty. We found this is really important, and as Kelly mentioned, it really injects the human component of we're here, we see you, we're here for you, and we're going to get through this together. And it seems ever more important when we know that what it means to do this together as a community is actually to stay apart right now. And so the resource coordinators are helping facilitate that component of the program. The next slide talks about the geography. So we've sorted the teams of case investigators who are supervising about 5 contact tracers apiece with the resource coordinators sprinkled across those teams. They're in geographic teams across the state of Massachusetts, defined by town as well as the local Board of Health structure, who have been critical partners and really the front lines of this before we were up and running in the Community Tracing Collaborative. So the geographic split here and kind of approach allows us to leverage local expertise of the folks we've hired, especially the resource coordinators, but it's set up in a way to also maximize efficiency. So if the team in Western Massachusetts isn't as busy right now, they can hop over to the Boston or metropolitan area to help with cases. So it's been important to allow for that flexibility as well. We did work on predicting our workforce based on the number of contacts we expected. And this has led to that lesson learned I mentioned about the fluidity between contact tracers and case investigators, because right now, during this time of social distancing, there's fewer contacts than we might expect in the future. So right now we're finding less than 5 contacts per case, but we had predicted around 10 contacts per case as things open up again. And the next slide discusses how we are training our workforce. So this is a big piece of the work. We do pretty rapid fire training over the first 2.5 days that then is followed with a lot of additional training and resources. The first day is self-directed, going through mini topics that you see there on the slide. And then they move into live webinars on video in day 2 with a lot of our experienced staff and leadership. And then they move into a lot of demonstrations and practice time with the software that they learn how to use. So that 2.5 days gets them ready to get on the phone. And then we've built in a lot of mechanisms to support them. This includes daily huddles with their team, a direct line to their supervisor, a help sort of virtual classroom that's open by video so that they can drop into. There's refresher trainings as protocols change. There's specific topics such as psychological first aid to support the people they're speaking with as well as the staff themselves. And as we identify new needs as our systems change and mature. And then we found a need for extensive documentation in written job aids, video job aids, and also clear channels to communicate questions. Every time we think we've locked down exactly all of the protocols, we will find a situation or a question that we haven't confronted yet. So we're learning a lot and adjusting this as we go. And with that, I'll hand this over to my to my colleague for the next slide.
Good afternoon and good morning, those of you around the country. This is Kevin Cranston from the Mass Department of Public Health. As you have heard, the Community Tracing Collaborative staff supports and coordinates with our local boards of health. In Massachusetts, each city and town is an independent public health authority. We have 351 of them, which may be different from your more county-based systems where you are. But our local boards of health, which employ public health nurses, physicians, epidemiologists, community health workers, are taking primary responsibility for these high risk and high priority cases. In particular, individuals or cases residing in congregate care settings, nursing homes, assisted living programs, behavioral health programs, for example, where, as we have seen around the country and particularly in Massachusetts, a significant amount of transmission are possible, and managing those at the local level is critical. Local boards may be handling individual disease clusters that they're already aware of within household settings or in a business environment, for example. And of course, are responding to outbreaks in healthcare environments as well, and working with the care resource coordinators, also coordinating on complex cases, individuals with extraordinary needs, as Dr. Rowe has described. And so this is a human-to-human connection between the CTC and the local boards of health. Next slide, please. As you've heard, having an EPI system of record, and in the case of Massachusetts, it's the Massachusetts Virtual Epidemiologic Network, or MAVEN. We know about 20 cities and states around the country are using MAVEN, but you may be using another electronic surveillance system or other mechanism for coordinating your cases. I want to reemphasize our core goal here is contacting every one of our cases, eliciting their contacts and tracking all of those contacts, making sure everyone has been informed of their exposure and their needs to either isolate or quarantine, depending on their status. The load of these cases and contacts continues to grow, and it clearly outstrips the capacity of many local boards of health, some of which reside in very small communities with limited staff capacity, and even some of our large cities and towns have indicated that they need support reaching all of their cases and contacts. On the left side of the screen, you see the traditional roles of the local boards of health, and they continue to see, if we could go back to that one slide, thank you. We continue to see the local boards of health continue to have visibility of all of their cases and their contacts in MAVEN. MAVEN electronically pushes out all the data from the centralized system to the local boards of health. And they continue to work on the cases and contact tracing for the ones that they retain. But they're able then to signal or to automatically allow cases to move over to the right side, which is the Community Tracing Collaborative. The CRM system is a parallel electronic system put to the CRM with enough information to be able to for the callers to be able to reach out to the cases to do the tracking. It also collects the contact information for follow-up by the case trackers, for the contact trackers, excuse me, tracers. This large workforce supplements that of the local boards of health. But there are triggers within the CRM system, such as if they identify a congregate care setting, it automatically pushes that case back to the local board of health. And as information is gathered by the case investigators and the contact tracers, that loads back into MAVEN and becomes visible again to the local boards of health, so they know the status of all that work. Fundamentally, this is a person-to-person communication, and particularly the case investigators and the care resource coordinators have direct human-to-human contact with the local boards of health to do problem solving on those high-risk cases and vulnerable populations. Thank you.
So next slide, please. As you may imagine, there are hundreds, if not thousands, of details that need coordination between various protocols, scripts, system design elements, and interfaces. But these fall within a framework of key guiding decision principles, among the most important of which you've now heard repeatedly, which is the governor will be working from one and only one set of incidence numbers which is the state's central Maven system, as Kevin just described. That we do need a software platform to support greatly expanded tracing efforts through call center activity, but that these two platforms must be interfaced bidirectionally. Some states may have the opportunity to implement more integrated platforms. And finally, there's an infinite amount of things that could be improved upon, but we have to get started with what is absolutely essential. You'll see other guiding principles as well, and I've noticed in the Q&As a number of questions about handling confidential information. And I should clarify that the systems being constructed are reviewed through our Executive Office of Human Services Systems Architecture and Security function. All DPH confidentiality provisions are flowed down to all vendors. Each contact tracer individually goes through privacy and security training and must attest to their adherence to the security provisions. And there is absolutely zero commercial usage of the information in these systems that is allowed. And the data all remains Commonwealth property. So next slide, please. On slide 22, we are providing a concrete view of the sprint-based development cycle of our contact tracing call center system, or CRM. We issue new functionality on a weekly cadence. A so-called minimum viable product, or MVP, was introduced with release 1.1 on April 12th that introduced the basic support for scripted outbound calling, with further improvements coming later that week. Last week in release 1.2, we released technology to support inbound calling and other enhancements listed under the release 1.2 column. And tomorrow we will be releasing so-called release 2.0, which includes better enhanced communications capabilities to cases, contacts, and local boards of health. And you'll see the soon-to-be slotted functionality under the column titled Release 2.1 Plus, with the aim of further integrating various modalities of interaction with both cases and their contacts. Next slide, please. As Dr. Kim said earlier in the deck, the governor is frequently asked, why hire all of these human tracers when automated technologies like Bluetooth proximity tracing or geolocation services could revolutionize the effort? We strongly believe, backed up by real experience, that we must pursue a both-and approach. To begin with, assembling a substantial tracing effort in a world where a centralized call center is not possible, that itself is a heavily technology-enabled effort. Also, there's much about the digital proximity tracing, which is hugely promising, but still remains to be built out and proven, and particularly in an open society where adoption is voluntary and the minimum degree of adoption necessary for material impact is unclear. More to the point, though, contact tracing is an activity characterized by enormous particularities of circumstance. Language barriers, technology variability, housing circumstances, local conditions and testing capacity, etc. So we are very keen on adopting automation supports as they develop, but foresee the need for both human and digital contact tracing supports hand in hand. And with that, I'll close the technology discussion and hand off to Francesco for an overview of communications and marketing.
Thank you, Luis. My name is Francesco De Flavis. I am the Chief Communication Officer for Partners in Health. As Kelly mentioned before, contact tracing is voluntary and requires active and voluntary collaborations of the public. For this reason, we realized it was imperative that a broad public awareness and engagement campaign for it to be set up as soon as possible to support the efforts on the ground. Because contact tracing involves sharing personal information and close contact, many residents may very well be wary of participating for privacy issues. Moreover, vulnerable communities might be even more reluctant to share information for fear of being singled out because of their legal status or other factors. So with that in mind, we set out to establish three communication objectives. The first one at the beginning was to inform all residents about contact tracing, basically discussing and arranging messaging points to address what is it, who does it, when it happens, why is it important, and how it happens, the details. Second, as it always happens in the age of digital media conspiracy theories, there's always misinformation that goes out. And we worked to dispel that information by putting all verified sources on the mass.gov website, which is very important ahead of pointing all the public towards one source of truth. The third objective was to develop messaging that was designed to foster adoption by removing those barriers, whether it's trust or fear that some communities may have. And for that, it was very important to develop a targeted messaging to understand deeply what each community's barriers might be. Next slide, please. So for the campaign, we are using a two-phase, two-prong approach. The first phase is meant to generate awareness about the program, and it starts right off the bat by telling people through a press release of the governor's office to start what is contact tracing, and explain the general details of how it works. This is happening while the infrastructure of the program is being built. The second phase is really meant to engage the public directly and foster that broad public adoption that we talked about. So started with a press conference, then major media coverage followed, international level, national level, and local level, which continue as of now. Simultaneously, we worked very hard to quickly set out, to stand up a multi-channel campaign, including social media, digital ads, radio, and TV. And this is because not everybody is obviously glued to their news TV station. And we need to reach the public where they consume information. And so obviously social media, radio, FM radio, and digital radio, TV, and also other means of digital ads as people are browsing online. Very important because of the mentions that of the barriers that we mentioned before, to adopt a two-prong approach. For sure, the top-down media approach is helpful, but we cannot succeed without a robust grassroots level engagement, working hand in hand with the leaders and the trusted voices of each community. To do that, we're working very closely with the governor's office and a local marketing agency to establish those local connections. And we're working to create a far-reaching influencer campaign as we speak. Language localization can be time-consuming, but it's critical to get the messages to the communities that speak other languages and to make sure that it's less alien, so to speak, from a message. And so that's important that all messaging, all ads, all radio spots are localized in different languages. One of the challenges that we see, obviously, was call blocking. So it's a feature of most phones that we are the calls from potential spammers are blocked. And so, as it was mentioned before, there was a lot of work done with providers to eliminate those challenges. But we also want to communicate to the public to pick up the phone. And so we communicated who was calling, what was the caller ID, and even what was the numbers that were to be expected. And so that hopefully will help with the ratio of call answer over call placed. Some scammers, as usually, there's always somebody trying to take advantage. So we're also trying to put out communication to identify those who are scams and those who are legit information. And then next slide, please. And here are some examples of creative ads that we are putting out right now. Obviously, I want to point out that in the times of social distancing, we found that animation was particularly nimble and a simpler way to get the message across. It also allowed us to represent the vibrant diversity of our communities without having to go out and film where it's not actually possible. We chose simpler call to actions to evoke love, protect loved ones, and also civic duty to support the communities that we are part of. And I want to point out lastly that we focused the initial efforts towards getting all the verified and useful information on the mass.gov website to be able to later on point out the public towards verified and comprehensive information, and therefore reduce the risk of misinformation. All the ads and all the messaging should obviously be consistent across all the channels. And with that, I'm going to pass to the next.
Hi, it's me again. I'm going to go quickly so that there's at least a few minutes for questions and answers. Everything needs a budget. Peoples and tools need a budget. On the left-hand side, you'll see the key additional budget elements that we focused on. And I'm going to highlight 5 very quickly. The contact tracing workforce obviously needs to be, it's the people and the staff, it needs to be funded. The CRM platform itself to capture and organize the information needs to be funded. The call center operations, the delivery of thousands of calls a day needs to be funded. The media campaign that Francesco just focused on needs to be funded. And lastly, I point to the project management office, which is a critical link in success. In the in-kind contributions, all of this is built upon the state's Department of Public Health and the local boards of health, and that we, as other states and other jurisdictions, are pursuing federal grants and matching funds. And we've had some terrific philanthropy and corporate in-kind contributions, including from Blue Cross Blue Shield, where the Massachusetts Blue Cross Blue Shield is effectively donating a portion of its call center to help with this. Next slide, please. So we're less than 1 month old from an operating perspective, and not surprisingly, but our risks remaining list is much larger than the risks resolved. And I'll point out 3 that have been spoken about earlier. But if you have a call center, if you're trying to reach people, a huge risk is getting people to answer the phone. So we have a huge effort focused on that. If you are operating a sophisticated CRM, then the continued need to implement new features is a risk, and doing that in an effective way. And if you're trying to integrate the information from 2 giant systems, the Maven system and the CRM, the ability for information to move quickly between the 2 is a risk that we're continually focused on. And risk resolved, I'm just blown away by the number of people that have applied, and therefore the quality of the staff that we've been able to hire. And I'm also blown away and thankful for our partners at Partners in Health and Accenture for their really world-class expertise that allowed us to stand up the CTC in just a couple of weeks. Next slide, please. And we are looked at this work for over the next year. April's the ramp up. Hire, train, launch the CRM and the call center operations. May to September is the peak run rate. This isn't necessarily the peak of the pandemic, but it matches the ability to take on, handle the increased testing that we know that will be done. And from October through March, which would take us to the year, we're calling it post-peak. We can adjust the scale of the operations to meet the need. We'll have a great ability to focus on hotspots, and this provides key support for opening up. And before we go to our Q&A, I'll turn it over, next slide please, to Dr. Kim for a quick summary.
Thanks everybody for being on. You know, we know that this is doable, and this is the most important message that we want to send. I think you've got some sense of the complexity, and every state, in fact, you know, every part of every state is going to have its own complexities. But the key is to get started, and get started as quickly as you can. Our hope, of course, is that everyone on this call will become part of our network, and then we can share experiences, share innovations, and finally, after too long, in every state in the United States get after this virus, box it in, and go back to what will certainly be a new normal, but it will be much, much better than the situation we're facing now. And so that's the most important lesson. Get started as quickly as you can. We'll be very happy to share this and our experiences that will be forthcoming. And we look forward to trying to answer some of your questions and continuing the communications. Again, we know we can do this. We have no choice. We're going to have to get down from the mountain of cases that we already have, but we've done this in much more difficult settings with much more difficult problems, like, for example, treating HIV in Africa. So this is doable, and we look forward to working with you on it.
Thanks, Dr. Kim. So we have a couple of minutes for questions. A lot of them have been coming in throughout the presentation, so I'll go through a couple at first as others are typing in. The biggest question we've gotten is, can we share this slide deck? And the answer is yes. We will be sharing the slide deck on the website posted on the screen right now. It will include audio. It might not be ready today, but it will be shared very shortly. And we will be sending out an email to all the attendees when it is posted. A couple of questions that have come in. One was, can the general public call into the CTC? No, this is not a function for people to call in and ask questions about. This is really outreach and outreach to folks that have tested positive and then their identified contacts. A couple of other questions around this that I'll just get to right now. We have learned over the course of a couple of weeks some key things about getting people to pick up the phone. Number one, leaving a message. We were calling and not leaving a message, which obviously gets people alarm bells up, especially with all the kind of scam and spam calls that go on. So we've started leaving a message. We're going to start texting people in advance of calling, saying, hi, we are the CTC. We're going to be reaching out with you about COVID. We will not ask for your social security number or your health insurance ID to kind of get to the scamming question. And then circling back to the original question, at the end of a case traced, we ask them, hey, if you feel comfortable and if it's safe for you to do so, please reach out to the contacts you just gave us and give them a heads up that we'll be calling them. So that's kind of, if people don't feel safe doing that for any reason, we will still call the contact, and we just won't say the name of the person that they came in touch with. We'll just say you are a known contact of someone who has tested positive for COVID-19 and move forward from there. The criteria, somebody asked about what's the criteria for vulnerable population. We don't have a criteria for vulnerable population, and this is really where the human-to-human impact comes in. Folks on the call get a sense from the conversation that they're having about whether a person's needs go beyond just kind of tracing, and communicate with the local Board of Health and the care resource coordinator in the call center to get those people the services that they need. There's a couple questions about what were the assumptions built into the model. How many staff were we going to hire per 1,000 cases? We did not go by cases, we did by calls. So we wanted to get to a point where we were able to do 10,000 calls a day, and how many staff would that take to do it? We had some assumptions around what the initial call would be. So the first outreach to the positive case, working through their obvious concerns and fears that they're now sick with something that's really scary, and getting the names and contact information of the contacts that they've been in touch with in the previous 48 hours, would take between 30 and 45 minutes. And then the follow-ups would take significantly shorter. So we built those numbers into our model to get to the number of staff that we thought we need to build up to. The Maven, there's a lot of questions about Maven. Maven is a relatively old system. It is from the mid-2000s, I believe. We did not do much changes to Maven, very, very few and pretty superficial. What we did was built the Salesforce capacity to be able to support the system that we had. And the bidirectionality between the Salesforce and the Maven is definitely something that we're still working on. It is not real time. We have a once a day data exchange, and we're still working through data cleanup issues. And again, we're building the plane as we're flying it, kind of lessons learned as we go. Another question was, I think, for Dr. Rowe. Could you talk about the staffing for PIH? Are they fully benefited? Are all staff salaried? If you could just talk about the PIH approach to hiring.
No problem. Yeah. So I mentioned we're using a recruiting firm with a lot of instructions from us to the type of people that we'd like to recruit. And then they are all on contracts at an hourly rate. So they are provided with health insurance by us, but not with retirement accounts and paid time off. So it's an hourly rate for their contracts. Anything else, Kelly? Or that's...
Can you explain, this is from Liddy from Delaware, can you explain the ratio of case investigators to contact tracers?
Sure. Hello, Delaware. That was based on estimates when we started, and we were estimating at the beginning that every case would have 10 contacts, which was sort of just a good educated guess based on our past experience. We have found that that ratio is actually, or the number of cases per contacts per case is a lot lower than that during social distancing. So as low as 2 and for some of the cases with a wide range. So we did each case investigator supervising 5 to 7 contact tracers. One lesson learned would actually be to keep those 2 roles fairly fluid between them so that anybody hired into those is trained to do case investigation phone calls and contact tracing phone calls. So we're catching up on that right now, and then still having that team lead supervising 5 to 7 people, because we know that as we go, we will have hopefully less cases, but more contacts per case as things open up again. So I think building in that flexibility from the start is definitely a lesson learned to communicate to everybody.
Thanks. We've had a number of questions with regard to how we funded this. The Baker administration fully supported the costs of this effort through the state appropriations. We are, of course, going to be looking at whether we can claim FFP on the pieces that apply to Medicaid patients, or if there is other, within the bounds applicable federal refunds opportunities there. But this was not private or philanthropic. It was part of the Baker COVID-19 budget. And then I think, Louis, I'd like to end with you. Can you talk about lessons learned from a tech point of view and how you would advise other states to start thinking about this?
I think the key thing is recognizing that you need to set this concept of the minimum viable product and the minimum essential data transfers. You need to start in a place that is easy to establish a toehold with before trying to solve for the big picture, though you should always have the big picture in mind. I just think it's important to be very practical. Big systems efforts, almost by nature, get complicated really quickly. The development, the testing, the training. And so it's always been my thought that I'd much rather have a very robust, very simple approach than have something that's complex and fragile.
Thank you. There are a number more questions, and I know there's a lot more interest, and I want to thank you for that. We are at time. My email is quite small, but at the bottom of the screen here, kelly.driscoll2@mass.gov. Again, this will be posted to the mass.gov website under the Community Tracing Collaborative Resources section. And, you know, we just want to say thank you and best of luck. We are all in this together. The disease does not stop at state lines. So thank you for your interest in building up this leg of the stool with us. Have a great day, everybody. Be well.